Good morning.
Good
morning,
morning.
everybody. Hello. Hi, it's 9 a.m. We're going to go ahead and get started. We have our cameras on for just a couple minutes here in our room, but we'll turn off our camera in a minute. But we just wanted you to see that there's actually people here in the room working with you today. So we're going to go ahead and get started. Thanks for joining us today. If you would please put yourself on mute. Otherwise, we'll mute you on our end. Okay, thanks, Summer. Thanks again for joining us. Today we're going to be talking about the Title 24 regulations for primary care clinics. We have a few slides for the purpose and background related information. And then the bulk of our time today is going to be discussing the actual regulations in Title 24, which is in section 1226. I'd like to introduce the folks in the room to you today. I'll put up, I'm sharing a slide right now that has the names of all of our folks. We have Richard Tannehill. He's a licensed architect. He's the Deputy Division Chief for OSHPD HCI. My name is Mia Marvelli. I'm the supervisor of the Building Standards Unit that all these folks work with. I also actually have Eric Jacobson, sorry, I was going to say Dreamer. He's from a different unit, but he's very familiar with clinics. I've got Samantha Miller, and she's our senior architect in BSU. On the line, remote with us today, is Jamie Schnick. He's a senior electrical engineer. I also have in the room today Larry Enright. He's our senior mechanical engineer. And to my right here is Simrit Pama. She's an AGPA with our office helping to facilitate this meeting. And I also have Clara Wu. She's the compliance officer in the Building Standards Unit. So I think I've got everybody here. So, all right, thank you. I'm going to go in and turn off our camera real quick so you're not distracted by us in the room. Okay. All right, let's get started here. So who are we and what do we do? Oh, I apologize. I actually wanted to introduce two folks that are on the line from the California Department of Public Health. We have Andrew Barbuska. He's a branch chief for CDPH, and also Nate Gilmore. He's also a branch chief with CDPH, and we do coordinate with CDPH on these regulations. Apologize, I forgot to read my notes. So. All right, I'm going to turn this over to Simrit. She's going to give us some housekeeping rules, and then we'll go into who are we and what do we do.
Hi, everyone. I'll be going over the housekeeping. So we will be having periods for questions and comments from the public. During this time, you will be able to raise your hand if you would like to speak. If you're dialing in, please press *5 to raise your hand. I'll be able to view the raised hands in the order that they're pressed, and we'll go down the list of raised hands. And I will call on you to unmute and ask your question when it's your turn. Please do not unmute yourself until you have been called on. The chat for this meeting is turned off, so please wait for the Q&A sessions to ask your question or say your comment. Additionally, you should have the option to turn on closed captioning for this meeting if you would like, and this meeting is also being recorded and transcribed. Thank you.
Thanks, Summer. Any questions before we move on how to provide comments? Okay. So periodically we're going to unmute. Okay, gotcha. Thank you. All right. All right, so who are we and what do we do? So today, this public meeting is being put on by the Office of Statewide Hospital Planning and Development. We are an office within the Department of Healthcare Access and Information. And we are the building department for hospitals, skilled nursing facilities, and psychiatric hospitals. We also have authority to promulgate regulations in Title 24 for licensed clinics through CDPH, including primary care clinics. And we'll talk about that a bit more. These regulations are coordinated with the California Department of Public Health for licensing and also to comply with their regulations in Title 22. We also coordinate with the Office of the State Fire Marshal for the fire and life safety features. And we also coordinate with the Division of the State Architect for the accessibility regulations found in the Building Code, Chapter 11B. But today we're focused on the OSHPD 3 Title 24 regulations. Those can be found in the California Building Code, the California Electrical, California Mechanical, and California Plumbing codes. And primary care clinics are defined in law, and I'm throwing out some more acronyms here, the Health and Safety Code in section 1204. And I'll talk about that in a little bit as well. So the California Building Code, section 1226.6, contains the architectural features for primary care clinics. We also recognize that in section 1226, it also contains regulations for other types of clinics, such as clinics licensed under a hospital license and specialty clinics. We'll cover this in a future slide. The purpose of today's meeting is to right-size the primary care clinics regulations. We want to hear from you all on the challenges that you face getting compliance for OSHPD 3 and also how the regulations read. That's really our goal, is input on that. We welcome any input on this, and we'll also be providing a slide in a little while that has a email address where we would very much appreciate email sent directly to us with suggested edits to the regulations, but also reasons why the change is needed. That is helpful for our regulatory process. We are also going to explore ways in Title 24 to amend so compliance can be efficiently accomplished. And we also would like to discuss how to update what we call a code application notice, a CAN. And right now that is number 1-7-2100. We're looking at developing that more into a guide that can have more examples of clinics. Currently, that CAN covers different types of clinics, and we're wondering if we should have different guides for each type of clinic, or maybe just subsets. So those are some things we're looking into. We'll talk about this a little bit in the future too, but we really would like your feedback by June 30th. I know that's a short timeline, but later on in the presentation, I'll be explaining the timeline for the regulatory process and the need for feedback as soon as possible. Okay, so let's just recap what is OSHPD 3, so we can set the stage here a little bit. So Title 24, as we've talked about, contains minimum building standards or regulations for the construction and alteration of all buildings and structures in California. Title 24 is comprised of building, fire, electrical, mechanical, plumbing regulations, energy and sustainability regulations. There's actually 12 parts to Title 24, so it's a large volume of books, we'll say. And our authority is to develop regulations for hospitals, skilled nursing facilities, and psych facilities, in addition to clinics that are licensed by CDPH, not all clinics. HCI and OSHPD amend Title 24, Chapter 12, and specifically Section 1226.6 for primary care clinics. And again, we talked about the law. I listed it here. The law defines primary care clinics in the Health and Safety Code. And just a reminder that CDPH is responsible for licensing primary care clinics and other clinics, and they promulgate Title 22 regulations, which oftentimes point to the Title 24 regulations. I'll just say that the law states back to 1204A, the law states only the following defined classes of primary care clinics shall be eligible for licensure, and those are called community clinics and free clinics. So all that said, we also it's also necessary to discuss 1226.4, and the reason for that is it contains the general construction requirements for clinics. The various sections for the types of clinics point back to 1226.4. for the typical general construction requirements such as exam treatment room sizes, corridors, doors, openings, interior finishes, garbage, trash, medical, so on and so forth. During a prior meeting with the California Primary Care Association and some architects familiar with primary care clinics, we found requirements that could be amended, such as clarifying the scoping and application sections. Also, when the clean, utility, soiled room and garbage, soiled waste, medical waste are actually required. And then also what can be shared. So we'll be looking into that as well. In addition, and this I know is a very common topic, is how many toilet rooms or fixtures are required for small clinics. And when Larry gets into his presentation for the plumbing code, we'll be talking about that a little bit more. We do see some opportunities there for clarification and allowances for smaller clinics. All right, so let me go through, while reviewing the California Building Code, the architectural features, we looked at the scoping and application sections, and we noticed that the charging language could be amended in a few areas, and I'll get there. So the slide I have up right now it shows all of the sections within 1226, and today's focus is primarily 1226.4 and 1226.6. So the scoping language at the beginning of 1226, the provisions of this section shall apply, and it points out primary care clinics include free clinics, community clinics. And what we're thinking is, would it be helpful to have some pointers to the health and safety code for folks? Because what often happens is we get calls about clinics in general, and we need to ensure that the owner and operator first determine, are they being licensed through CDPH and how? And these laws tell them that. So we thought there would be an opportunity to add some of these health and safety code pointers to that. And then, as I pointed out, here's section 1226.6 that says basically clinics and outpatient clinical services under a hospital shall comply with the provisions in this section, except where modified below. Should we better clarify what types of clinics must use 1224? So that's something we'll be looking into. Here's the charging language for outpatient clinical services of a hospital. I'm not going to read it all, but there may be opportunities here to clarify some information here. And then, of course, here's the charging language for primary care clinics. So primary care clinics and outpatient clinical services of a hospital that provides services equivalent to primary care clinics shall comply with 1226.4.3 through 1226. That's back to the general provision and the provisions of this section. And then lastly, we're looking at the blue text here is we recognize that there wasn't really a header, if you will, for specialty clinics. So we're suggesting to add a header for specialty clinics and clarify surgical clinics. If you look at the rest of the code, the rest of the specialty clinics have a special header. This is just informational. Okay, so let's look at the comparison. Before I move on, we're gonna dive into the comparison table for the architectural features. But before I move on, I want to open it up for any questions.
If you have a question, please raise your hand and we'll call on you to unmute. Joe, I see you have a question. You could unmute and ask the question, please.
Yes, the code changes that are being considered for primary care clinics, would those also be extended to hospital outpatient services that are being that are equivalent to primary care clinics, or would hospital outpatient services be excluded from these proposed code changes?
It kind of depends on where the overlap is. So for example, if we're considering for a very small clinic to, we'll say reduce the fixture count, that possibly could help the clinical under a hospital license.
Okay,
As a
that's
general
helpful.
rule, Joe, that the hospitals under the clinics under a hospital license are capable of seeing up to 25% inpatient. So the standards will be held to a higher level.
Right, I understand that. With my experience doing almost 24 hospital outpatient clinics, most of them are, virtually all of them are remote enough from the hospital that they would never send an inpatient over there. You know, they're like a block or 2 blocks away. They have to be within 250 yards, but I understand that provision, the 25% provision, but it results in a lot of overkill often.
Understood, but they are capable of seeing inpatients, even if they transport them.
Thank you.
Mm-hmm. Anybody else with them? Okay, so just a brief overview of the comparison table, and I'll call it up here in just a second. It's broken up into different sections. So the first section we'll talk about are the features in the California Building Code, and then Larry will talk about mechanical plumbing, and then Jamie will talk about the electrical part. Let me pop over really quickly to, here's the table. Okay, it's presenting. All right, good. So we've got 4 columns here. The first column, the first 2 columns list the requirements, items, rooms for the primary care clinics. And we summarize the Title 24 section number and requirements pertaining to the item. So it's not the full text. The next column is Title 22. Many of the Title 22 regulations are related to space needs, operational functions, or reference back to Title 24. And then the far right table is our OSHPD comment. These comment notes are based on prior discussions with the Primary Care Association and architects familiar with primary care clinics, and also a lot of the questions that we do get on clinics. We took their comments and edited the OSHPD comment column for today's meeting. You'll see that some comments say to be addressed in a guidance document, because what we're finding is there's really little opportunity to change the regulation because it might be out of our authority, but we can certainly clarify it in a guidance document. And one example is corridors, which we'll talk about a little bit in a minute. And then, as you can see on this table, there's some rows highlighted items, and those are either out of our authority or they're minimum building standards. Some of these might be state fire marshal related that we don't have the authority to change. Some of them might be access, and in some cases they're kind of the minimum requirement. So that said, we also have identified that these may benefit from further clarification. For example, there are several requirements for corridor widths depending on the patient care. And for the most part, primary care clinics would not need to meet the higher standards. This can be clarified in a guidance document.
Can you clarify rows and rows?
Yes, rows colored, highlighted, rows highlighted, ROSE, versus the ROW row. Sure. Okay, all right. I'm going to move on to the first part of primary care clinics, which is the general provisions, which is in 1226.4, which many of the clinics point back to. We'll talk about corridors a little bit. So I think the key here is outpatient clinics and outpatient departments consisting only of waiting rooms, business offices, doctor's offices, and exam rooms, where there is no traffic through such area or other services or exits, shall have a minimum corridor hallway width of 44 inches. So there's a lot of wiggle room here for just the minimum 44 inches. There may be instances where you have to meet the 5 feet. And I'm going to go through all of these and then we'll pause for questions on that. So just keep rolling here. It's probably pretty rare that a clinic would have, I mean, again, we're not talking about surgery clinics here, but it's pretty rare that we would have a clinic with bed and gurney patients that would require the 8 feet. Contiguous functions is a very helpful section, which provides a lot of flexibility for services to be shared within the clinic. So I don't see a need to edit that, but if somebody has suggestions, we're happy to hear about if any edits need to be made to contiguous functions. I have toilet room doors listed here. That's a minimum width that we really can't edit. I have pocket doors listed here. So what we're finding is we get a lot of questions about, are barn doors allowed? And we've done some research and there are barn doors are allowed in exam rooms and treatment rooms. And so we may add an edit that explains barn doors.
Also, we're looking at if the doors should swing outward in the clinic.
In the toilet room? Okay. Not really much to say about windows and screens. Those are not required in treatment rooms or exam rooms. So that's really for patient rooms. We get a lot of questions on the minimum height, ceiling height. Right now, the minimum ceiling height is 8 feet. We understand that this can be challenging when you're modifying an existing clinic. We actually have in the CAN, we have, the checklist that we have for clinics. We do have a provision that allows the ceiling to be at 7'6". If you're remodeling, yeah, if it's an existing clinic. Again, we have to set a minimum in the regulations. We had a hand up for that one. We can pause and go.
We have a raised hand from DW. Do you want to ask your question?
No. Lowered hand? Okay. All right, I'll keep rolling here.
We have a raised hand from Glenn.
Okay, Glenn.
Yeah, good morning. A clarification on what you just said, Mia. When you say existing clinic, is it an existing licensed clinic or is it a non-licensed space or place that was providing medical services that's becoming a newly licensed clinic?
It's supposed to be a previously licensed clinic.
Okay, thanks.
Yeah, thank you for that.
So,
No?
no, it's an unlicensed clinic that's trying to get their license. Because their previous license is probably going to already meet the requirements. So that's why we're allowing a little flexibility for the non-licensed clinics that are trying to get licensed to become OSHPA 30.
Okay. All right.
That makes sense, Glenn?
Sort of. It really depends, Richard, and we can talk offline with some of the stuff that I've seen come in before. But I won't belabor this point.
Yeah, but we're trying to put some flexibility for existing conditions that, like a exam room that doesn't quite meet the 80 square feet. There's going to be a minimum cited in the guidance to say that we're not going to make them make the exam rooms larger. And so we're looking at those as options. That's
yeah,
all.
the difficulty at times is doctors' offices wanting to become licensed clinics.
Understood.
Okay, just my pauses. I'm just making some notes here. Thank you. Thanks, Glenn. I'm going to go kind of fast through interior finishes here because we're really not, we don't seem to get a lot of, we did get some comments on wall base and code base. We're going to take a look at that. We may have an error in some pointers. But this is pretty basic minimum need for infection control. Yeah, I thought I heard someone, sorry. Again, elevator, this could use some clarification in the guide, but the reality is the elevator cap sizes are out of our authority to change. Those are either state fire marshal or ADA requirements. Okay, so now we're entering into the actual primary care clinic section. Exam rooms, we've talked about this minimum of 80 square feet with a minimum dimension of 8 feet. It does require them to have a hand washing fixture and accommodations for documentation. Treatment rooms are optional, so we have some minimum sizes for the treatment rooms. I'm going to skip dental. It's pretty rare that a dental service is provided in a primary care clinic, but the features are there. And this, I think one thing I forgot to mention is when the clinic regulations were first developed, we paralleled the federal guidelines, outpatient. And while California is not mandated to adopt those, they are a national standard that's used for reference as a basis for the code. So there's support areas for the examination room. Just hold on one second here. So the nurse station, perhaps there is an opportunity for a code change here. I think traditionally nurse station was considered, support for patient rooms, but this area can be combined with other areas and can double as a charting station. So we'll look into this a little bit more, but this is also could benefit from some changes. Medication station, this is really, you just have to have something within the visual control of the staff. And this could be clarified in the guidance document. And it doesn't mean that you have to have an entire medication station. And then we get into areas like the clean utility, soiled workroom, garbage, soil waste, medical waste. There seems to be a lot of questions on what's required and how and the sizes for these, because there aren't really, I think there's only one of them that has a minimum size standard. But what we need to know is they must be, in many cases, that these must be separated, because what we're trying to do is minimize the risk of cross-contamination here in infection control. This includes separating the clean and the clean and dirty areas. That said, if minimal space is needed for housekeeping, again, if you have a small clinic and you don't need a lot of space, you can use a cabinet or closet, and the same for clean utility, soiled holding. These can be small areas as long as they're separate spaces. Anything to add on that? This consultation room is actually for dental facilities. Sterilization facilities, this is if it's needed. You may not need sterilization facilities in a primary care clinic. Same with lab facilities. So then we get into the support area for the patient. You do need to have a separate toilet for the patients within the clinical space. This is separate from public use, and the purpose for that is they may need to use the restroom immediately off of an exam room, and they should not be passing through a publicly accessible area. We'll be looking to that in the future, but this probably won't change because this is a requirement. Specimen or blood collection may not be necessary in a primary care clinic. So again, this is voluntary. It says when provided. And then we talked about garbage, soil, waste, medical. We'll consider this as a code change. We're going to look at FGI to see if clinics without invasive imaging or internal medical examinations require all of these infection control measures. We'll also look at Title 22 and CMS. So housekeeping, this overlaps a little bit with the plumbing code. Janitorial housekeeping room needs to exhaust outdoors. We'll talk about that a little bit later. It overlaps with the mechanical code as well. Just like a toilet or a shower or laundry room. So that's a need for this to be separate. When we've got reception areas and outpatient waiting, back in here. We can if you take a look at contiguous spaces, we can combine this and we can clarify this a little bit more in the guide. You know, normally you have reception, you have your medical record storage there. You can have a lot of things going on in the reception area that accommodates the outpatient waiting room. We talk about public toilets. Again, those public toilets can be located within the building. They do not have to be in the waiting area. I think that's pretty clear, but we can take a look at that. For smaller clinics, we're going to consider possible sharing toilets with, there is a provision that allows for smaller clinics to share the public toilet room with the staff. We'll double check with that.
Patients.
No, with patients, I'm sorry, the patient room. And then public accessibility, this public telephone, we're looking into, can it be a non-wired telephone? So if you have internet service, I noticed that the FGI requirements have been changed that says as long as there's Wi-Fi. So we're looking into whether you actually have to have a hardwired public telephone access. We're also looking into, is it necessary still to have a drinking fountain? Title 22 says that the construction should be in conformance with Title 24. So this may have been a carryover from FGI. I talked a little bit about medical records being combined. Again, we know that this is going electronically, so a computer station could be sufficient to meet this. And then equipment storage and supply is simply storage area for the administrative needs of the clinic. And then we're looking into the staff toilet ratios. Could there be could we do a change to look at if a clinic is less than 10 staff or occupants, reducing that down to one toilet?
That's a Cal OSHA alignment
The two, the male, female?
to be shared at 10.
Okay. And then storage for employees, all this requires is a lockable drawer, storage, or cabinet. Doesn't have to be a whole locker room or anything for clinics. So I can pause there because we ended the architectural features and open it up for some questions for the architectural features, and then I'll turn it over to Larry.
We have a question from Bill. You could unmute yourself and ask a question, please.
Yeah, good morning. So on slide 2, regarding the corridors, I've got a suggestion or an area that I find confusing. The information on what we can share is kind of tucked away in corridors. I'm wondering if it ought to have its own separate heading. So the contiguous functions, that code section really speaks to, you have to have a corridor that connects all of your stuff inside your clinic. But the exceptions to that explain you can share this, 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 and this. And a lot of our people end up looking, they'll remember there's some place in the code that it says we can share certain things. Where do I find that? And you wouldn't think to look in the corridor section of the code. So that's my comment.
Okay,
Thanks.
thank you. So some sort of a pointer.
Or relocated. I think to Bill's point, I think in the hospital code, it's in the charging language that at the beginning of the support that these things have to be per unit, but these things can be shared.
These, okay,
So maybe we have something at the beginning of 4.
mm-hmm. I'm just making notes here. Okay, thanks, Bill.
Thank you, Bill. We have our next raised hand from Glenn, so you could go ahead and unmute, please.
Yes, good morning again. One thing about primary care clinics, abortion clinics and dental clinics are both considered primary care clinics. And it might be helpful to code users to maybe further distinguish those as having, I guess, a little more specific requirements for when those types of services are being provided. It can't always be a closet as a matter of course for some of those procedures that go on in those clinics.
Yeah, I'm glad you brought that up, Glenn, because when I looked at the dental stuff, I kind of felt like it's kind of in a weird spot. I don't know if it makes sense to sort of separate it, have primary care clinic and then have a separate section for dental and separate for abortion. Just a thought. One of the other comments we received, and it's not on here, is the idea of perhaps saying what services can be provided in a primary care clinic. And we need to talk to CDPH about that a little bit, because right now the charging language just says primary care clinics shall comply with the following. But like other types of clinics, it says what's being done in there. And so it's our understanding that primary care clinics, it's like a first stop, right? It's your basic, you're going in, you're seeing your doctor for the first time, and then they may recommend that you go see someone else. So I'm not sure to the extent of how many, I hate to use the word invasive procedures are happening in a primary care clinic, but that may be helpful for the code user too. I don't know if anyone else has experienced that. Yeah, I think we can go to the next.
Our next question is from Joe, so you can go ahead and unmute, please.
Yeah, just a couple comments. One being the requirement for outswinging doors at the patient toilet room that can, particularly for an existing medical practice that's trying to get licensed, that can be problematic. That requirement harkens back to the hospital code section 1224, where it makes sense because often patient toilet rooms and hospital rooms are very small. And if a patient were to collapse off the toilet, it'd be difficult to push the door open. With our handicap accessible sized toilet rooms, there's typically quite a bit of room inside the door for the door to swing in, even if a patient is collapsed. I'm just wondering if that might be a requirement that could be, the outswinging door requirement could be removed for outpatient clinics.
Good point, Joe. We are looking at that right now. It's probably going to go away with a requirement. If you put nurse call in it, it may require the outswinging doors because there should be a reason to have nurse call. But right now we're looking at removing that requirement in the clinic space because you don't have the same type of acuity of the patients there.
Right, great. The other comment or just kind of a clarification. You note about clarifying the guidance, but the medication station requirement, which again refers back to um, the 1224 requirements. It seems there seems to be some distinction needed between the type of medication station you would have in a small clinic, where it might just be a locked cabinet behind a locked door in the clean utility room, versus the more extensive medication rooms that you would have in an acute care hospital.
Yeah, we agree 100%.
Great, thank you.
Thank you.
Thank you, Joe. Our next raised hand is from Eric, so you can go ahead and unmute, please.
Hi, yeah, I wanted to go back to the topic right before that regarding the type of clinic. Our organization is in the middle of discussing this very thing where we have an existing licensed clinic. I think on our license specific, it's an oncology clinic, but the space itself, I know there's not a separate set of requirements for each type of patient that might be in the space, but it's a licensed clinic, and we would like to change the type of patients that are going to be in the space, but we don't need to change any functions or use of the spaces. And it's already, again, we'd maintained it under the same license. So I don't know if this is a specific code requirement or code change that would be needed, but I think that's a potentially confusing topic as to what is permissible there. If you're not changing any function or use, but a license might say it's for oncology patients, even though it's for the most part a basic clinic, and you want to start seeing neuro patients in there. So just potentially some clarification on that could be helpful, because I'm not sure CDPH would have crystal clarity on that either.
I was just going to say, normally that's handled between CDPH. Sometimes they do require us to look at the space to make sure all the functional requirements are there, in which case we have what we call a non-construction project that you can submit to show before and after. It's expedited through the system, and actually it doesn't go into construction. You get your certificate of compliance right out the door, and you can turn that over to CDPH to address those needs if it's something they request. But we could try to provide some guidance in that in the guide, but that is something we do pretty much weekly here.
That's helpful. Just for clarity, in that instance, would HCI be looking at that even if it's potentially non-construction as the current code, if it was licensed prior to maybe the last code cycle or two, or just potentially at the time of original construction?
Really, I'd start with CDPH because they really shouldn't be asking us for a change in service. If you're going from like one clinic to another, we're typically not contacted for that. But like I said, depending on what it's changing to, they may request that we take a look at it. Mia, did you want to add to that?
Well, it's a little tricky because the OSHPAT 3s go to the local jurisdiction. So if you know, yeah, I don't know how much we would be involved in it changing services from one to another. It's a CDPS.
CDPH
so they would
make the
ask
request.
this. Okay,
Yeah.
I see.
Like I said, it's rare that they would
Okay.
approach us on that because we don't have the jurisdiction, but it has happened before, but it's been pretty rare. But typically, if you're just changing service, and Claire, if you want to add to this, typically you're changing service, it should be strictly with CDPH because like you said, the space is not changing, and that's when we get involved with the space changes.
Yeah, you're right.
Okay.
Thank you.
But Eric, you kind of bring up a really good point here is if we OSHPAD get into putting amendments in there about the types of services, and then we don't have something in there, we don't want unintended consequences of complicating the primary care clinic section either. So, right now it's pretty open and broad, and maybe we're just covering the minimum services. And then if this is provided, you need to do this. Maybe that's how we cover it.
Right. I mean, I think
Okay.
one of a potentially confusing component could be the terminology of primary care clinic instead of just outpatient clinic, just regarding potential patient use, right? The spaces are the same, the process is the same. It's just oncology patients versus cardiology patients versus, primary care patients.
Got it. Okay. Okay, thank you. No more raised hands? Okay, all right. Well, we're gonna do a little room shift here, so bear with us. We're gonna, I'm gonna turn this over to Larry for mechanical.
Hello, I'm Larry Enright, Senior Mechanical Engineer on the Building Standards Unit. Yeah, switch down to Part 4, California Mechanical Code. Pretty far up there.
Yeah.
Yeah.
Okay.
All right, here we go. So just a little background. So OSHPD includes amendments to the model code related to healthcare facilities. And when we started, many of these were based on the U.S. Department of Health and Human Services guidelines for construction equipment in hospital and medical facilities. Those have since then branched off to the Facility Guideline Institute and then ASHRAE 170 for ventilation of healthcare facilities. And so for OSHPD 3, it's broken up into OSHPD 3 with surgical clinics and then OSHPD 3 just general. So I'm going to cover a couple of the highlighted sections today, but looking for feedback on these amendments, that'll be appreciated as we look into the applicability of these amendments for the lesser acuity functions. And then I want to just point out that there are also some minimum code provisions in the model codes that apply to the primary care clinics, and those cannot be reduced by OSHPD. However, the specific applications might be able to address some of those issues and some of the guides that we're looking into developing. So first up, highlight, so natural ventilation. So ventilation is required to be primarily provided by mechanical ventilation. I just note that secondary ventilation can be natural if there's windows, but essentially the mechanical continuous operation is required for clinics. Under the continuous operation provision, that it's supposed to be operated continuously anytime the building's occupied. There are exceptions in there for unoccupied mode to be permitted, and that's for the exception, and that aligns with Part 6 energy codes. So next one to cover was the exhaust fan. So one of the requirements is for the exhaust to be at the discharge into the system, and this creates negative pressure ductwork. This might be something we could possibly look at for lower class systems. We have some exhaust that might be classified as a lower 2 or 3, and we do get the higher 3 and 4 hazardous exhaust. But this is amendments intended for. Next up is the outdoor air intake. This is a 25-foot clearance to ensure the intake's safe from other hazards. Potential be looking at there's some table A2 spaces in 170 that could be brought down to model code. So for ventilation, 407.3.1, this is where we bring in our ventilation table 4A. So the ventilation, a lot of these ventilation rates are in coordination with ASHRAE 170, looking at bringing in additional ASHRAE table A2 spaces into the table 4A to have a little bit lower ventilation rate for the lower acuity spaces. Plenum spaces, OSHPD does have an amendment. However, model code does too. I'm currently looking into whether certain lower acuity spaces could potentially use up return air plenum. And then moving on to filtration. Filters, typically, if they require MER 14, require a pre and post filter. Currently our table 4B's filtration requirements is based on the original healthcare requirements. So we're looking at bringing MERV filtration identified per each space, and potentially many clinic spaces can have a single MERV 13 pre-filter. So that'll be something to look at in the next code.
Larry, I have a question. So are MERV filters required regardless if you're OSHPAT 3 or not?
Yeah, so basic clinics, we have mechanical code, but part 6 energy code and Cal Green required MERV 13 for non-licensed clinics.
Thank you.
Air ducts off by the 7 minute for limitation. We extend the model code 5 feet to 10 feet just due to the hospitals and other spaces having really congested ceilings. And then there's some other items here that we just brought up: odorous rooms.
You mentioned fund and duct, fund and return. Can you explain when fund and return might be acceptable, that we would consider to be acceptable versus ducted return?
Yeah, so the lower acuity spaces. So there's clinics with a consult or
So in other words, people that aren't sick,
yeah,
so
non-sick.
maybe rehab,
spaces.
counseling, et cetera.
Yeah.
Thank you.
And then should we take questions now? Just part 4. Is there any questions currently with mechanical code provisions?
We have a question from Glenn. You could go ahead and unmute, please.
Good morning, Larry. I'm back.
Good morning.
Right now, OSHPAT adopts the 2013 edition of 170 and further amends it a little bit. But in the 2017 edition actually was expanded to address outpatient settings, including, of course, primary care clinics. And the requirements really are lessened in those facility types. And it is the national standard referenced by the federal government. I noticed it's being pulled into model code in the next model code edition, but could OSHPAT possibly get to the 2017 or the 2021 edition of 170 in order to allow these facilities to benefit from those code changes?
Yeah, correctly. So the 2025 will adopt the 2021 edition.
Right.
We have a lot of code provisions back from in the California codes that date back to the 80 editions of the Health and Human Services Guidance.
Right.
So getting into the 2013 to the 2021 was a big lift. And we're in the intervening code looking at additional ways to implement a lot more of the 2021 edition requirements.
Yeah,
So you're correct.
I think it would be really beneficial to get to that table 8.1 earlier rather than later, in an interim possible adoption for clinics at least.
Yeah, and we could look at even doing a CAN, some more guidance documents for any intervening
Excellent.
changes that are made in the intervening cycle that aren't quite applicable until that later July
Gotcha.
timeframe.
Thank you, Larry.
Not just 18.
Yeah. What's that? Okay, so we'll go ahead and move to part 5 for plumbing code. So the main item here is plumbing fixtures, and we've been trying to look at the last couple code cycles is looking at fixture counts and how model code requirements and then the facility requirements from the FGI kind of combine and intermingle. There are some, at least for the lower or smaller type facilities, is some ways that we can look at adjusting the code or making things more clear to get those to align a little bit better. However, the main concept is the fixture counts are based on providing separate facilities for patients, staff, and public or visitors. So intermingling those 3 components is what we're trying to prohibit with the facility requirements. So the current clinic provisions allows for shared public and patient fixtures for clinics with no more than 3 exam rooms. Again, the public, if it's a main facility, it can share the main public restrooms outside of the clinic. However, one of the intervening code changes we're looking for is when staff can use a single facility compared to having separate male and female and then working the male-female counts into the overall picture counts.
So the staff one being addressed in the future code amendments we're looking at?
You are looking at the 2025 interview.
Right, thank you.
Moving over, so potable water materials. So for CPVC is not permitted under OSHPD. Don't want to point out that the chapter 1 plumbing code allows existing materials to remain. Actually, we do have some guidance on underground services.
Yeah, this is the plastic piping versus cast iron. There is a prohibition of CPVC in healthcare facilities.
Yeah, and then the cast iron we throw the waste. The waste is ABS, CPVS is currently prohibited. OSHPD's looked at previously, and we're not able to change that. So another item is hot water redundancy. So we previously put in an exception. It should be now for clinics doing only hand washing, where they don't need to have redundant equipment. Usually have smaller water
So
heaters.
that's already in place. 'Cause I heard that the other day from people.
Yeah, I think that one was in the last the July supplement to 22.
Okay.
And then hot water temperature. So hot water recirculation, that's in 25-foot max branch lakes. That's to limit Legionella. As far as dialysis water systems, we have received previous provisions that have helped adjust the material provisions that allow such as CBC and PEX. So that's been a process. Other than that, that's all I have for part 5. If there's any questions, we can go ahead and take those.
We have a question from Joe, so you can go ahead and unmute yourself, please.
Yeah, just with regard to number of plumbing fixtures, I think it'd also be helpful to clarify when separate sex or multiple toilet rooms are required for the waiting area. That sometimes comes up in local plan review.
Okay, thank you.
Thank you, Joe. We have another question from Eric. You can go ahead and unmute, please.
Yeah, question on the cast iron for the waste piping. Just we've come up to a couple scenarios where we have ABS underground, and wondering whether there have been any discussions about possibly allowing that underground in existing facilities that we were trying to convert.
Yeah, so in our okay, that's fine. Yeah, so I think that's our current clinic checklist. So if there's an existing building, come in to do a licensed clinic. Do not need to do underground can remain is what it's in our current.
Yeah, if you have under slab PVC, it's allowed to remain in place, even if the cast iron dumps into it.
Thank you.
Thank you, Eric. We have another raised hand from Bill, so you can go ahead and unmute, please.
Yeah, good morning again. Hey, Jamie, question for you on quantifying the number of staff for this toilet room exercise and how many toilet rooms we need. When you go through the regular process to determine occupant load and therefore how many toilets you need, it doesn't separate out how many of those occupants are staff. So what we end up doing is saying, well, how many people are we going to employ in this clinic, which is kind of imprecise. And we're always wondering if a local building department is even going to accept that. So I don't know if that's a code change thing or if that's a guidance document kind of thing, but that would be helpful to know. How are we supposed to quantify number of staff?
Yeah, that's a good
First of all,
point.
you want to make sure you're using the right table.
Yeah.
We consolidated everything into table
4.2.
4-2 now for staff, patients, and public, correct? Sorry.
It mostly points to 4.2. So the model code looks at floor area. A clinic or hospital, it's identifying how do you apply floor area to either patients or staff or public. Waiting area is usually pretty simple to get to public, but a lot of the other areas mix. So Maybe in the guidance document, we can look at using the FTEs, lay equivalents, the full-time, it's the full-time equivalents to do a staff count to figure out high load of staff ratios or only fish count for staff.
And one of the things we find with Bill, as you're probably aware, is that once we determine the number of occupants in the space, it becomes, for the code book, 50% male, 50% female. In California, we convert the same number of required fixtures to all gender. So that kind of sets our, so the fixture count doesn't change from that, but it's also, which is actually, I would think would help facilities because they be used either way. But what we're trying to really clarify is when we can get one.
Yeah, and I appreciate that, and I'm tracking along in your explanation. When I go to that table 4-2, it says 1 to 15. So I know if we have 15 or fewer staff members, one toilet. But how many of our people, how many staff do we have? I can't do a square footage calculation to definitively tell you this is how many staff. I have to count up my exam rooms and speculate. I think we're going to hire 12 people to man this clinic. That's how many staff we'll have. Then I can go to the 1 to the 15 and say it's one toilet for our 12 people.
Right, and that's what we would typically see, because we don't base it all the time on the square footage. We do base it on the needs for the clinic. Because
Okay.
usually that's lower, because especially if you have a bunch of exam rooms, but you only have so many staff operating them. So we would accept your interpretation of the number of staff working in the space and use that number. Again, we can add some guidance to the guide for the local jurisdictions to follow on that.
Thank you. Appreciate it.
Yeah, and what we're trying to do, Cal OSHA allows for if you have 10 or less staff in an area, you can use a shared toilet. That's not a federal requirement, it's just California. So we're trying to work that into this somehow as well.
No questions. Okay, so I guess
Any more questions from anyone before we go to electrical?
Oh, we just got a raised hand from Brett, so you could go ahead and unmute, please.
Yeah, this is Brett. The question I have is relative just on the top right here. Once again, Richard, I believe we heard that when the word existing materials to remain, whether it's a conversion from a medical office building to a clinic, that would still apply?
Yes.
Okay.
Yeah, all right. I think right now it's pretty much under slab. There's remodeling work inside the space. That's new materials.
Okay, thank you.
Yeah, that is something that was not interpreted that way in the past. So it is actually a newer interpretation. So if you've ran into that in the past, hopefully that'll be avoided in the future.
Excellent. Thank you.
Thank you, Brett. We have another raised hand from DW. You could go ahead and unmute, please. It looks like you're still muted, so I'm not sure if you're talking.
No, we can't hear you. All right, we'll move on.
Okay, so next up is Jamie. I'll turn it over to you.
Switch over to the power.
Great, thank you.
You want this first? Or you want the PowerPoint?
We can show this and then I'll move to the PowerPoint. So in general, the requirements for electrical are fairly straightforward. The only one that might be cause some concern is the grounding requirement for the patient care spaces. So let's go to the PowerPoint, if you could, please. In general, here's a summary of the code that would come into play. Standard GFCI protection is required. The patient care ground fault current path is required, what's usually understood as redundant ground path with the metal raceway and ground wire. Lighting is required for all habitable rooms. And then there is code sections, no special requirements for X-ray facilities and mobile medical facilities, and nurse call systems per table 1224 if imaging exam procedure rooms are present. Next slide, please. So the ground fault requirements are similar for any building, you know. Specifically bathrooms, kitchens, rooftops, outdoors, when you're within 6 foot of a sink, indoor wet locations, all require ground fault interrupter protection for personnel. Next slide. Now I'm going to go through real quick just definitions because it applies to the requirement for redundant ground path. Patient care area is defined as areas where patients are intended to be examined or treated. And typically we would see that we're going to have in our clinics either category 3 basic care spaces or category 2 general care spaces. The general care space in which a failure of equipment is likely to cause minor injury. The basic care where failure of equipment is not likely to cause injury. Next slide. So the reason I went through the definitions of patient care areas is because the code requires that patient care areas have redundant ground path. And so that means the wiring method would need to be in a metal raceway system, or a cable having metallic armor. And this would require an insulated copper grounding conductor. So this would not permit, for instance, plastic pipe that's typically put in the conduit, in the concrete to service tables or chairs that are in the center of the room. That would have to be routed in a different manner. Next slide, please. Artificial lighting, nothing too special. All rooms and passageways shall be provided with artificial illumination. And then our code 51722 requires that you meet the recommended values in the latest edition of the ANSI IES recommended practice 29. Next slide. And again, not exceptional, but this is requirements that could apply. The mobile medical facilities requirements in 517.124. There's really nothing exceptional. Sizing of feeders is required to meet the standard code, and service receptacle shall be listed for use, and the disconnect shall be located at the trailer. Same thing with X-rays. We have the code sections that apply to that. It allows, for the supply branch circuit, not less than 50% of momentary or 100% of long-term, and it has the diversity factors for when you have multiple X-ray units. Next slide, please. Here's a table that point identifies the nurse call requirements. I will note, if you take a look at note 1, where next to the patient toilet room that requires a bath station, there's a note to the table that says it's not required for primary care, chronic dialysis, or these other clinics. So specifically, the only really requirements for nurse call would be if the facility has an imaging exam room or imaging procedure room. And that should do it for me. Any questions on electrical requirements?
I don't see any questions. Oh, we just got some raised hands. I see our first raised hand is from Lou Lavasa. You could unmute, please.
Hello.
Yes, this is Lou at the Children's Clinic in Long Beach. So with the reference to the nurse control station as it not being required for primary care facilities, will CDPH then adjust their site survey to not require that? Because we've seen it in audits where they've come out and said, oh, you need a call station or a nurse call button in the restrooms. And I was like, well, we're not a, overnight facility. That's typically required of a hospital, not a primary care clinic. So based on what you just presented, will that also be relayed to CDPH in their site survey?
Yeah, we
It
can
should be,
certainly,
yes.
we could certainly reach out to them. I think some of them are in the meeting today, right?
Yeah.
That would be great. Thank you.
Hi, this
Yeah,
is
that
Nate.
was a, go ahead, Andy.
I don't know if Andy's on as well. This is Nate Gilmore from California Department of Public Health. We can take a look into that and try to get a response for you. Unless Andy, if you do have something here that you can say.
Oh, hello, this is Andy. Can you hear me?
Yeah.
Okay. Yeah, we would need to look into the specific situation. Any patient that potentially has a medical condition that might require some alert from a care area to staff is important. So we would have to evaluate the specifics rather than just sort of painting that with a broad brush. So appreciate your question, and that's something that we can look into.
Thank you. Our next question is from DW.
Yes, good morning. Will essential services or emergency power be required for primary care clinics?
Only if it's considered a surgery center.
Okay, but the patient room, no emergency outlet provision.
Correct.
Okay.
Thank you. And we have another question from Jayana.
Yes, thank you, Jaina. I just had a question. I feel like infusion's always a kind of a gray area, and gets interpreted in different ways, just with when it's OSHPAD 3. So, where would you, I guess, categorize infusion? I know previously it was comparable to chronic dialysis or dialysis, but I think that's changed quite significantly. So with getting rid of the I-2.1. So where would that, you think, be located in this designation?
We still see it as equivalent of dialysis.
Okay. So then it's not
Okay.
considered a treatment space? Because it says it's not required for primary care, chronic dialysis, rehabilitation, or psychological clinics, psychology clinics.
Yeah, they both would fall under the new ambulatory care facility.
Perfect. Okay,
Thanks.
perfect. Thank you.
All right, thank you.
So
Oh.
I'd just like to revisit the previous question about emergency receptacles. So the code is pretty clear that for category 1 critical care spaces and category 1 spaces are where a power outage could likely cause loss of life, that you're required to have the receptacles at the bed. For category 2, that requirement for patient bed receptacles has an exception that says that those requirements don't apply to patient bed locations in clinics, medical and dental offices, and outpatient facilities. So we did look at that thoroughly and wanted to make sure we were giving good information, but that's why I said when I talked about the emergency system for a surgery center, that would apply to if it's a clinic that provides surgery, that would apply to the patient bed. You'd also need to have the receptacles. So I hope that answers your question.
Yes, it did. Thank you.
Sure.
Do we have any more questions?
Okay, thanks. All right, so homework. Well, first of all, very much thank you for your feedback already today. We would truly appreciate any written comments, and we'll go. I see another questions coming up. We'll go back to you in just a second. We need feedback by the June 30th. You can send it in an email format. You can make comments on the document that's on our website. Please use the subject line primary care clinics public meeting. And the meeting material, there's a link here. We will be putting this PowerPoint on our website where you found the other meeting materials. I'm going to spend just another slide here talking about timeline, and then Claire is going to talk about the guidance document in just a minute, and then we'll be done with today's public meeting. So Larry, let's go to the comment first. Sorry.
Glenn, we have a question from you. You could go ahead and unmute, please.
Yeah, quick one. Sometimes I see these hospital outpatient services providing primary care services, and the 25% inpatient limitation really kicks up the notch for their facilities. It's really not equivalent. And that language, when it went into statute, was really to provide a level table for surgical clinics and hospital outpatient surgical settings. Is there any future consideration of either OSHPD or CDPH pursuing some additional clarification in that arena through legislation? And I know you might not be able to answer this. Maybe that's food for thought, though.
Okay.
Thank you.
Lynn, could you send that in maybe with a little more detail?
Okay, or I can call you or come and see you too.
Yeah, do that.
Absolutely.
Thank you, Glenn.
Okie doke.
Thank you. We have another raised hand from DW. You could go ahead and unmute, please.
Hello, can I ask a question about means of egress?
Sure.
There was comment about the 44-inch rule, minimum clear. Any thoughts on if the corridor is double loaded, two-way gurney traffic?
So I don't have the code section in front of me, but generally a primary care clinic isn't going to have gurneys going back and forth, so it wouldn't need the 8-foot clear.
Okay. Yeah, because 44 was the minimum, I think, in that slide for earlier on. So it wouldn't be an essential requirement for primary care clinics.
Most likely not, because primary care is probably not a surgery, right? It's a surgery clinic. Surgical clinic is 1226.8. And primary care is generally not doing surgery.
Okay,
Yeah, that 8 foot is more for hospitals and skilled nursing facilities where you're moving patients.
understood. Thank you.
Okay, sure.
Thank you. We have another question from Jana. You could go ahead and unmute.
Thank you so much. And I'm gonna just piggyback off this question, and I apologize in advance. I missed the first part of this, so if you did cover this, I apologize for repetition. There is also a code section that has ambulatory care clinics with gurney traffic at 6 feet clear. And again, we had some confusion designing an infusion clinic that would have some gurney traffic just because there would be some patients coming over from the hospital. So with that, are we at 44? Are we at 6 feet clear? Are we at 8? I guess how would we determine where that would fall?
Yeah, infusion would be 6.
Okay, perfect.
Yeah.
Thank you.
Thank you. Do we have any other questions?
Okay, all right, we'll move on to the next slide. I'm just going to take a couple minutes. I want to give you all the timeline of what we're doing this for the remainder of the calendar year, just to give you an overview. So today is our first public meeting for primary care clinics. And then we'll be taking the information that you provide us, and we're going to be drafting the language, any amendments to 1226 over the course of the next couple months. In August, we intend to email out our draft regulations to the interested parties list, which is how you found out about this meeting today. And we will ask for some feedback on that. These will be the draft regulations. And then in August, we will have a second primary care clinic public meeting. We don't have the date set for that yet. This is a little bit in flux, as you can understand, because we don't know, the quantity of the code changes at this point in time. And then we're going to be working on the guidance document. So the guidance document would be based right now on the 2022 code, which is in effect. We'll also look at is there anything in the 2025 edition of Title 24 that we can include in there too. So we're going to publish that guide later this summer. So internally, we have to have all of our regulations complete and go through the internal approval process by October. We legally have to submit our code changes to the California Building Standards Commission December of 2025. And then that launches their public process, which is also several opportunities for public comment during that time. And then if they're approved by the commission, they will be published January of 2027, and they would go into effect as the blue supplement for the 2025 code, and the effective date would be July of 2027. Before I turn it over to Claire, are there any questions on what we're doing over the next 6-7 months? Okay. All right, I'll turn it over to Clara to talk about the guidance document.
Okay, thank you. So I'm Clara Wu, Compliance Officer. I'm going to talk a little bit more about the guidance document and the checklist. Like Mia mentioned earlier, we will be updating the CAN 1-7-2100 clinics to a guidance document separating the different type of clinics. We will also updating the associated checklist. These documents would be based on the current 2022 regulations And the guides will be edited in the future to align with any future Title 24 regulations developed as a result of today's efforts and the next code cycle. The guidance document will assist design professionals, primary care clinic owners or operators in the local jurisdictions on compliance with the current editions of the Title 24. And the checklist I think the next slide is the checklist. Sorry, yeah. Okay, the checklist will provide a list of the applicable building code sections and used by the design professionals and the local jurisdictions when checking compliance with Title 24. So our goal is to have the guidance document and the checklist ready by later this summer. So this is about the guidance document and the checklist, and if any additional question about this.
Feedback. Okay. So that homework slide we had up before, that's the same email address. So it's the regs unit at hchi.ca.gov. You can send in comments about either the existing CAN. I mean, that's the best thing is you can send in info on the existing CAN or the existing checklists that are on our website. And also comments on the any proposed code changes. So any comments before we close out this meeting? I think we're at an end here.
We have a raised hand from Eric. You could go ahead and unmute.
Yeah, I just wanted to ask the best way for us when we're dealing with local jurisdictions on these, with what's going on, the best way to try to either gather knowledge or make sure that they are informed. I've seen some inconsistency with the way local jurisdictions might approach or be aware or have knowledge of the requirements. And so with this checklist, the guidance, the potential modifications, the best way from an owner's perspective to help direct and or make sure that local jurisdiction is gathering as much knowledge as they can from HCI.
Actually, that's a great point. So we're aware of that, and actually we have local jurisdictions that will reach out to us about clinic questions, and we point them to the guide or the CAN. We point them to the checklist, and then we also talk about certain flexibilities when reviewing the clinic projects that they get. Just some FYI for everyone on the phone is we do reach out to local jurisdictions. We've had local jurisdictions ask us specifically, can they have a overview of the OSHPD 3 clinic regs, and we've done that for several large jurisdictions. I'm in communication with Calvo, and I've offered to do like a webinar where they can post that to their website. So my recommendation for specific clinics that are going through the review process is the design professional can certainly give the local jurisdiction our contact information. We are careful about, let's say, intervening between a design professional and a local jurisdiction, but we are happy to help talk to the local jurisdiction about if we were receiving this clinic project, what would we do? So we've done that before.
Thank you.
And you can offer them that regsunit@hchi.ca.gov email. It's a central location, and I'll be honest, when we receive an email from the local jurisdiction, we try to get back to them very quickly. We try to get back to everyone within 24 hours. That can be tricky sometimes, but we do sort of elevate local jurisdiction questions.
Do we have any more questions?
Oh,
say goodbye.
Yeah. So we shared our screen here. We're gonna turn our video back on. And I very much thank everyone for their participation today. If you have any questions, shoot it to that Regs Unit email. And then also watch for an email from us for our next public meeting. And thank you again for participating today. It's very meaningful to have these public meetings and get your feedback. Okay, with that, do you have any questions?
Yeah.
Oh, you have another question?
Yeah, we have a question from Glenn. You could go ahead and.
Hi, Glenn.
unmute.
Hi, it's just a comment. You guys are doing good work. I want to say that.
Thank you, Glenn.
Thanks, Glenn.
Thank you. We have another raised hand from Lou Lavassa.
Hi, yes, I was just thank you for this presentation. It was awesome. Great information. And then follow up to that is when would the next public meeting be?
We don't have a date set, but we're looking at the month of August.
Great, thank you.
Yep. Thank you. Okay. All right. Thank you very much.
Thank you.